Today on this post-election day, all of us trying to figure out what happened last night day. So we are talking today about outreach and enrollment assistance for people with HIV, some lessons learned from the first year and looking ahead. You can download the slides and materials at hivhealthreform.org, so we encourage everyone to do that. We are unfortunately not able to have take questions live, so we encourage you to ask questions using the question feature, and then we will go through questions towards the end of the presentation. If you're having audio problems, if you can't hear, click on the audio tab and dial the telephone number you'll see there. Often that helps with audio. And then once again, please download the slides from hivhealthreform.org. They're right on the home page. We will have the webinar recording available in a few days, and we will send you an email when it's available. We're also going to be live tweeting today, and here are the Twitter hashtags we'll be using, so follow along there and comment and share and whatnot. And then also, of course, check out hivhealthreform.org, which is the repository for a lot of great resources on open enrollment and other issues. So today we're going to start with some comments from Melinda Elwood at the Harvard Law School Center for Health Law and Policy Innovations, Big Picture Lessons Learned from 2014. Stuart Landers of the ACE TA Center will be talking about some of their resources. Jen Cates of Kaiser Family Foundation will be talking about some of their resources. Amy Killalay from NASTAD will be talking about AC enrollment and Ryan-White coordination. And then Lauren Banks will close us out with by talking about their experience in Alabama as a navigator. So I'm going to turn things over to Melinda. Go ahead, Melinda.
Thank you, everybody. Appreciate you all being on today's webinar. So we're going to head over to the first slide, and I have promised to be very brief this morning, so you all can hold me to that. In the midst of everything we're hearing about last night, I do think it's important to start this webinar reminding ourselves how much we've accomplished over the past year. This was part of some data that was gathered through Enroll America and published in an article recently through the New York Times, which I encourage you all to check out, because in reality, if you go to this link, you can actually get pretty specific county-by-county figures at how much health insurance, the rate of uninsurance was decreased, or the rate of people having insurance increased with respect to specific regions of the country. And so I do just want to remind us all, on perhaps maybe a dark day, that we did accomplish a lot through open enrollment last year, and we have our work cut out for us moving forward. So first slide, next slide. Again, we have our work cut out for us. Clearly, there are some populations through a lack of Medicaid expansion and otherwise where we really need to be upping our game and improving our efforts even further. Next slide. So again, just to remind everybody, how do we know where we are? You know, what are we doing to sort of understand what folks are experiencing, the good, the bad, and the ugly with respect to open enrollment, with respect to actually accessing coverage? We get a lot of this information directly from you because you do participate in our Speak Up project. This is a project that many of you are familiar with at this point, I hope. It's funded by the MAC AIDS Fund, and you can visit us directly through hivhealthreform.org. And there's a very simple form to fill out that just lets us know if you're experiencing any kind of issues or concerns, or if you're experiencing something great with your health coverage. We want to know about it, so please do let us know. This is how we're able to collect specific stories, specific examples of what's going wrong and what's going well, and we are able to share these examples with our federal partners. Next slide. So lessons learned from 2014. Again, if you've been on a webinar or any kind of presentation with me over the past 6 months, you've heard us talk about this. I think some of these are ones we're all familiar with. Clearly, lack of transparency was often a barrier with respect to open enrollment in terms of choosing the right plan. We also know that some plans had inadequate formularies, for instance, failing to cover all single tablet regimens like Atripla and other medications. We saw many plans placing HIV medications on formulary tiers with high levels of cost sharing or co-insurance. And then we also saw an increased placement of HIV medications on tiers requiring specialty or mail order pharmacies or having other kinds of excessive prior authorization requirements. And then as we move forward, we've also had some difficulties with ADAP, Ryan White, and QHP coordination, although there are certainly a lot of success stories there as well that I know Amy will be talking about in the next part of the webinar. So next slide. So how do we address these barriers? Again, I think I've spoken in much detail about some of the policy solutions that we're pursuing, and I think there are some good news to kind of share with everybody, and there are some specific steps we can all take together to move forward. The good news is, and I say required in quotes because this may not be, it may not roll out as we would hope, but in theory there are requirements newly issued in the issuer's letter for 2015 that plans provide direct links from the marketplace to their formularies and provider networks, and that they make really clear which formularies and networks apply to QHP, a particular QHP. Do I think that that's going to be perfect, or do I think that that's going to solve the problem? Probably not, but I would expect and hope to see some improvement. But again, please let us know as you move through this process whether or not you're able to find the right information. As far as what we can do together, I think it's clear that we still need to provide information just on Insurance 101. You know, things like what does a deductible mean? What does it mean to have a co-insurance requirement? What is cost sharing? What is my premium instead of cost sharing, et cetera? You can find a lot of great resources today that we're going to talk about that will help you talk through this process as well. It is really important to prepare, I know, in all of our spare time, but still really important to prepare as much as we can in advance. And that really means, if possible, doing some advanced plan review to the extent that the documents become available. And I would say that we don't have to do this alone. There are many other chronic disease coalitions who are interested in looking at these plans in individual states. California, I know, is working on some specific plan review through Project Inform. I think this is the time to really band together and try to help each other so that we're not reinventing the wheel every time. And don't forget, although enrollment starts November 15th, that doesn't mean that you have to select a plan on that day. We still have some time. It's far more important to pick a plan that's actually going to work for you than to be enrolled the second day of open enrollment. And then finally, ensuring consumers and clients are aware of what kinds of information to look for. Again, you're going to hear a lot of information about tools that are available to help with this process. Just some, 4 basic requirements here that I listed. With respect to understanding what networks your provider's in and making sure that your medications are covered. So next slide. Moving forward, other avenues and resources for advocates that I just want to make sure we don't forget about. Everyone has the right to appeal both an adverse enrollment decision and an adverse coverage decision. So don't forget about that individual right. We do have resources. We've done webinars on that in the past, and we're here to help with that if you need it. Don't forget also about filing grievance with insurance companies. This is a different process than just filing an appeal. Filing a grievance is more akin to sort of filing a complaint about the insurance company as a whole or a process that you went through with them. Those do get looked at, so please do that if you're experiencing a concern. Many states also have a consumer assistance program and or an ombudsman program for specific issues with Medicaid and Medicare. Next slide. So the big picture, again, just to remind everybody, throughout 2014, we have been working with many of you, and there are many others outside of our community who are working to really change and address some of the bigger issues that we've seen. So that includes, filing complaints with departments of insurance. We've talked before about Illinois and what they've been able to accomplish with their department. I've included links here to some of those success stories so that you get a sense of some of the examples. We've also partnered with the AIDS Institute and NHELP to file a complaint with the Office of Civil Rights about some of the issues that I mentioned with respect to placing HIV medications on high cost-sharing tiers. We continue to see and to think about how best to use the court systems to bring change. And then finally, we are also working through the HIV Healthcare Access Working Group and many other groups to do advocacy at the federal and state level. And I just want to say again, please do share your examples, the good, bad, and ugly with Speak Up. And I will turn it over to the rest of the group to tell us more about what resources are available to help.
Great, thank you so much, Melinda. And now I'm going to turn it over to Stuart Landers, who's with the ACE TA Center project, and John Snowink. Go ahead, Stuart.
Thank you so much, John. So the Affordable Care Enrollment, or ACE TA Center, was funded by HRSA, HIV/AIDS Bureau, with the Secretary's Minority AIDS Initiative funds. And what you're looking at is our program model, which is we were funded just a little over a year ago, and we conducted a 2-pronged needs assessment. One was a grantee survey that I'm going to tell you a little bit more about, and the other was a best practices assessment, which is really looking at a lot of the work that's been done to date, including a lot by folks on this webinar, and then looking at what doing a gap analysis to especially look at what is relevant and what is working for people with HIV of color to help ensure and support their enrollment in Affordable Care Act health insurance options. As a result of that analysis, we've developed a set of responsive tools to support outreach and enrollment for Ryan White HIV/AIDS program grantees and providers. And then, of course, we're evaluating our overall effort. Next slide. So the center objectives are to provide tools and resources to help providers enroll clients of color, always considering cultural and historic barriers to enrollment. Next, please. And also to build grantee understanding of the needs, back one, sorry, for the culturally competent O&E strategies, to provide technical assistance and training to promote the use of these tools and resources, and to enhance the capacity of Ryan White Part A and B grantees to support their sub-grantees. The providers include both Part C as well as the sub-grantees that we are charged with working with. Okay, so as I said, I'm going to briefly describe the needs assessment that we did out in the community. And we developed an online needs assessment tool to gather information from Ryan White program grantees and direct service providers about their experience linking eligible clients to new healthcare coverage options. The survey, done in both English and Spanish, was distributed in December 2013 through a variety of mechanisms, including direct email, the Target website, social media accounts, such as AIDS.gov, and through various HRSA HAB project officers, their newsletter, as well as, again, national providers, partners, such as folks on this call. And it was sent, as you can tell, from December 13 during the first open enrollment period, and particularly when there were still a lot of difficulties with the website. So that may have influenced some of the findings. Next. Overall, however, we did receive, in the end, 231 final complete surveys that came from 45 states, including and the District of Columbia, Puerto Rico, and the U.S. Virgin Islands. And the largest number of responses came from where you might expect, the largest states, Florida, New York, Illinois, California, Pennsylvania, and Texas. These are also states with highest HIV prevalence rates, highest number of minorities living with HIV. They actually account for 50% of Ryan White clients and 40% of Ryan White grantees nationally. Next slide. So while there were many similarities across the grantees and the providers, there were differences that we found based on Medicaid expansion versus non-expansion, the type of insurance exchange, whether it was a federal marketplace or a state or a joint marketplace, and also enrollment capacity, which is part of what we assessed in the needs assessment. And so we've learned that TA and training needs to be different for these grantees and providers. Next. So just a little busy, but just wanted to highlight that we divided up the responses by the direct service providers and by the health departments. These were the health departments that do not also provide direct services. Some of the health departments do as well, and we counted those as direct service providers. But they had slightly different needs in terms of some of the highest needs they indicated. For both, the lack of information or knowledge among clients was the greatest need. Ineligibility due to immigration status or fears related to immigration status were the next highest for the direct service providers. as well as then previous negative experiences with insurance that would make clients distrustful or nervous about enrollment. And then finally, the provider's lack of familiarity with health insurance coverage and the ACA. Okay, thank you. So overall, what we found was that there was limited knowledge and experience with many direct service providers facing general outreach and enrollment challenges due to the lack of knowledge around new coverage options. And we've heard already, some discussion about ways to obtain some of that knowledge. And that the TA needs would vary based on the local circumstances. Next. Finding 2 was that there were barriers to accessing care, particularly working with minority clients who historically face barriers to accessing care and may not be comfortable enrolling in the new ACA coverage options. Concerns about plan affordability and the potential for having to change providers, and that both outreach and enrollment capacity and cultural competency are critical to enrolling and retaining minority Ryan White clients in ACA coverage options. Next. And then communication and coordination remains critical, that a lot of the Ryan White grantees and providers were looking for more guidance about policies and best practices. There was still a lack of clarity about certain policies, such as vigorously pursue coverage option, and that there might be gaps in coordination related to, would have implications for how the clients experience their care. So again, for communication and coordination, we need strong guidance from state and local health departments, information about state and federal ACA policies, training to assess coverage options for clients, and collaborations between state Ryan White and state Medicaid programs. Next. Okay, so in response to this, we've come up with a series of training and TA strategies. Next. And so we are encourage you to use the TA, our website, which is www.targethiv.org/ACE. Next slide. And we really just wanted to sort of underscore again that it's our charge and mission to work and work with diverse clientele and communities of color. And so it's really important to know that all of our tools have been filtered in a variety of ways to ensure their cultural competency. Okay, with that, next slide we'll go on to a number of the resources that we've developed. We're excited to share them with you next. And the tools have been developed to go across each step of the continuum of enrollment, which while we're going to be in the re-enrollment period now for many clients, and I'm going to be talking about that. But of course, it's a new open enrollment period as well, so a lot of these tools are sort of applicable both for people enrolling for the first time as well as for people who are re-enrolling. Next. So one of our central tools that we're using is the web page called Resources, Tips, and Tools for Ryan White HIV Program Clients in Coverage. It's also known as the Online Enrollment Resource Guide. It's organized around the steps that I showed you before. And this is really something that takes you step by step through the enrollment process. And so I think it's an online tool that I think is really the first place to go. Next. The eligibility decision tree has been one of our most popular resources so far. It's had the greatest number of downloads. And it's a one-page resource that's easy to use and takes you through a series of questions to which your clients can answer yes or no to assess whether they're eligible for health coverage or not, and how ADAP fits in with their other coverage. It starts with very straightforward questions. Is the client's a U.S. citizen? Do they already have Medicaid or Medicare? And you can work your way down with it to really decide where you need to go. And again, all of these tools are part of the online resource guide that I showed first. Next. The healthcare plan selection worksheet also helps you with addressing whether a qualified health plan is the right plan for the client. So it includes sections on what their current medications, providers, and pharmacy benefits are, and then you can compare that to what's in the potential plans for them to enroll in using some of the resources that have been developed by HIV Health Reform and other organizations. Next. The enrollment fact sheet is a tool that recognizes that there are varying levels of experience among enrollment staff in terms of working with people living with HIV and AIDS. So this tool can be applicable if you are working with organizations that maybe are not HIV-specific organizations and they need some guidance on how to work with clients who are HIV positive or have AIDS. And it could also be useful if you have new enrollment staff who are not familiar with working with people with HIV/AIDS before. And this really covers some distinct topics such as medications, continuity of care, stigma and confidentiality, and affordability that are really critical issues for people with HIV and AIDS who may be moving on to health insurance. Next. So this is called Common Questions and Suggested Responses for Engaging Clients in Health Coverage. And this is really intended to help guide early conversations with clients about really the benefits of health insurance and what it means to have health insurance rather than to be on a grant program such as Ryan White. It's not intended to be a script, but rather to prepare ahead of time for these conversations between enrollment staff and clients and provide reassurance both for the clients with respect to the issues they have, but also for the enrollment staff so that they have familiarity with what they are addressing. Next. This is that same tool in Spanish. Next. And this is a plain language glossary. I think one of the things we're all hearing over and over is that health insurance literacy remains low, both among the client population and, frankly, among the provider population, particularly within the HIV/AIDS community, which for many years has not really needed to rely so much on insurance to cover people in need of services. This is an alphabetical glossary designed specifically with enrollment and people living with HIV and AIDS in mind. Next. Okay. And this is it in Spanish, and it actually has a dictionary that translates between the English and Spanish terms. Next. This is a new tool that's just come online in the last month for the special enrollment period, so maybe not specifically relevant for the upcoming new enrollment period, but will be helpful as we go out of that period. Next. Okay, and this is, again, the website where you can download most of these tools. A couple of them are online only. And then next, just a little preview of where we're going. Next. Yeah, thank you. So just in general, we're working on more job aids for staff doing outreach and enrollment. We're moving now from the interface between enrollers and clients to also providing more resources at the organizational level. We'll be doing both remote and in-person consultation to organizations and jurisdictions. We have some webinars coming up and some web-based and in-person training resources. Next. So mark the calendars. Thank you for letting us put in our plug. Next Wednesday at 3:30 p.m. there will be a focus on plan renewals and open enrollment for 2015. That which will also include a re-enrollment flow sheet that we're working on. And then on Monday, 11/17, we will be working to help think about managing the coverage gap and sharing some best practices in states not expanding Medicaid. Next. And again, some resources that are coming from us soon include an enrollment tracking worksheet to track your flow of clients in your organization, the flow chart for renewals that we will unveil next Wednesday, some information about tax credits and cost sharing reductions, and then just best practices for organizations. And last but not least, just this is who we are. And so any questions or comments that don't get answered on this call can go directly to us at the ACE GA Center at jsi.com. Thank you.
Great. Thank you so much, Stuart. There are some fantastic resources there, and we will send out in the follow-up email and also post on HIVhealthreform.org information about upcoming webinars and some additional information. So thank you so much. And now we're going to turn things over to Jennifer Cates, who is with Kaiser Family Foundation, who's going to talk about some of their resources, which are really targeted to consumers. So different side of the same coin. So go ahead, Jen.
Thanks so much, John, and thanks to HIV Health Reform for giving us an opportunity to share very briefly some resources that we have. And as John said, I think these are a nice complement to what Stuart was presenting, because what we saw leading into the first open enrollment last year was a need to help consumers with HIV understand what options they might have for new insurance. So we set out to develop a site specifically for consumers with HIV to navigate their options. And right now what I'm going to just briefly walk you through is that site, but updated. We've updated the site. Here's the sort of home page look at it, part of it. And it's called, we've actually renamed it, but it's called Health Coverage HIV and You. And what we've done is update to make it current for the next upcoming enrollment, open enrollment, and change some of the content. We also, I just need to thank a lot of people who are probably on the call for providing us feedback last year, participating in some calls with us to get feedback to make the site as user-friendly for consumers as possible, and that's something we very much hope to continue. Next. So just a few things that we've done to update it. First, we've renamed it. We had been calling it Obamacare, and now that health reform is hopefully here to stay, despite what you might be reading about, we are calling it Health Coverage HIV and You, because really the site and all of what we're doing is about helping people with HIV understand their options for health insurance coverage. So that's the name of it. Some of the new features we have, or updated features, we have sort of a highlight of what are the 5 most important things people with HIV need to know. So if someone comes, they'll just get that highlight. We have a Find Your Story feature that really just sort of, and I'll show you a picture of this in a minute, but it really just says, if you're coming at the site and you're someone who is uninsured, or you're someone who has Medicaid, or you're a Ryan White client, what does that mean for your situation? We have also common questions, more than 75 at this point, that are specific to people with HIV and the ACA and what it means for them. We have state-specific information on a whole range of issues, and a lot about how Ryan White interfaces with the marketplace and with Medicaid. And we have other tools that are available both from Kaiser and other sites. We do provide a link to HIV Health Reform at the Speak Up, and are always looking for ways to enhance an opportunity for consumers to get the help that they need. Go to the next slide. So this is just the sort of stories that I was mentioning. If you come to the site, this will be one of the first things you see. So you can see the scenario that you might want to understand, and it helps you walk through what the ACA would mean for you if you're in one of those buckets already. You're on Medicaid, or you are a Ryan White client, you have insurance through your employer, and you have HIV. What do you need to know? You can easily go to common questions, as I mentioned, on those 75. And on the right are a bunch of the features that we make available to people, including a checklist. We also have a checklist, which is very similar, but it's one that a consumer would be able to take with them to their doctor, so it's a little simpler, I think, and it just provides that for them. We have a glossary. We have a community toolkit, which allows community organizations to download many of the materials into one packet and use them with their clients. And then finally, we have all of these resources in Spanish, and not all of those are updated as today. They will be updated before open enrollment. But again, I just wanted to emphasize that this is an ongoing project that we at Kaiser are engaged in and excited about, and hope to make as helpful to consumers with HIV who are coming directly to the web for information before they go to their Ryan White case manager, or before they have interacted with a doctor, or maybe after. But this is really a consumer-based interface. So we look forward to continuing to get information from the community about what would be most helpful, and hope that you'd be able to direct consumers to the site if you think that would be good for consumers. So thank you. I think that was the last slide I had. And this is just another one that you can actually go and see what your options are based on what bucket you fit in. We also have, I should say, we have a calculator that allows you to see what subsidies you get in the marketplace and other options. So thank you very much. I really appreciate, again, the opportunity to participate.
Great. Thank you so much for those great resources, and we encourage everybody to check them out and share them with consumers. And again, they're available both in English and Spanish. And now we are going to turn things over to Amy Killalay from NASTAD, the National Alliance of State and Territorial AIDS Directors. Go ahead, Amy. I have to unmute you. Sorry, Amy. Hold on. Okay. Sorry, Amy, you're unmuted now.
No problem. I just kept on talking. So thank you, and thanks for the invitation to participate on today's webinar. What I'm going to do is focus on open enrollment and coordination with the Ryan White program and AIDS drug assistance programs in particular. So next slide. So what I wanted to start out with, and sort of the big takeaway from this sort of busy slide, is that open enrollment is upon us. We've got a week and a half until November 15th when the second ACA open enrollment period starts. And I think the takeaway there is that we're on a compressed timeline. Last year, as you'll recall, we had an extended open enrollment period that began October 1st and ended up running all the way through March of 2014. And what we found, with Ryan White case managers and ADAPs and folks out there doing outreach and enrollment work on the ground, is that we needed every moment of that open enrollment period. Some of that was due in part, and in no small part, to the significant technical glitches that healthcare.gov and even state marketplaces, the website portals experienced. But a big part of what took a long time and what was particularly challenging for people living with HIV and Ryan White programs really assessing plans was, as Melinda referenced, a lack of transparency in terms of availability of plan information. So it took a while to figure out what was the plan's formulary, what was the out-of-pocket cost associated with the plan, and what plan made most sense both for an individual enrolling in coverage and then for an AIDS drug assistance program who is purchasing or helping to purchase coverage for an individual. So we're on a compressed timeline, and I think that really all goes to say is that ADAPs and outreach and enrollment workers are really gearing up for a frenzied couple of months. And then just to sort of, as a reminder, in order for the earliest coverage effective date for the 2015 benefit year, people have to enroll by December 15th. That's sort of the same rules that applied over the last year of having to enroll in the first 2 weeks of the month for that earliest coverage effective date. So that means that a lot of the action and a lot of the assessment is going to be happening November 15th through December 15th, which is coming right up. And the other thing, just to say, Medicaid, unlike qualified health plan enrollment, it's continuous enrollment throughout the year. So we're going to continue to see folks enroll in expanded Medicaid. And I think, we're also going to see states take up the Medicaid expansion that haven't yet. And we already know that, Pennsylvania is going to be starting very soon its Medicaid expansion, and enrollment will be starting there too. So that's another consideration. Next slide. So, I think we probably discuss a lot of the lessons learned and the challenges that were encountered in the first open enrollment period, but just to sort of boil it down to 4 of the most significant challenges, and then the strategies that programs have embraced, will embrace this coming open enrollment period. I wanted to talk about the sort of the top four. And the first one, and this was something that was a challenge in many states and continues to be a challenge, is that participation in ACA enrollment and really, ACA implementation has been limited or prohibited by state employees in certain states. And we've seen at least one state have new restrictions on who can participate, which state employees can participate, and the extent of their participation in ACA enrollment activities. And that really did cause a barrier for ADAP participation, in particular in state health department participation in transitioning clients to qualified health plans in those states. So, strategies which I think, are relevant not just to states where it was tricky, the ADAP and state health department participation, but really in every state, is that it was very important for ADAP to be working hand in hand and very closely with community-based organizations and coalitions to really coordinate an effort around client education, enrollment efforts, ADAP transition efforts, and then any ADAP insurance purchasing that accompanied, client transition to qualified health plans, and that's going to continue to be important. The second challenge, which it continues to be a challenge and one that states are continuing to work on, is the coordination of payment between ADAP and qualified health plans has been difficult, and Melinda referenced this. And I think part of that is it's complex. We're adding a third party to a payment system where ADAP is paying a premium and or cost sharing for a client who's enrolled in private insurance. So the client is getting all of the plan correspondence, letters in the mail, the invoice for the premium, and then that has to go to a third party, the ADAP, and then the ADAP cuts a check and sends it to the plan. And somewhere along that line, there have been sort of hiccups and problems with the payments being processed in a timely manner and applied to appropriate accounts. So ADAPs and state health departments have really tried to be creative, cultivating relationships with insurers, contracting out payment duties, working with insurers to really figure out what are some of the best practices that make most sense for all concerned, and that's continuing to happen. The third sort of potential challenge on the horizon is coordination of ADAP and tax credit reconciliation. And I'm not going to say too much about this because I'm sure we'll have a whole webinar dedicated to tax credit reconciliation come January through April. But the coordinating the ADAP paying any premium amount left over after the premium tax credit has taken a lot of front-end work, and I think some of the takeaways to keep in mind is that, first of all, ADAPs are already working with clients to help educate folks about reconciliation, about the need to take the full amount of the tax credit in advance, to report any income changes to the marketplace, and also the need to file taxes for the year in which somebody receives the tax credit. So that's the earliest that's going to be is come April of 2015, people are going to need to file their federal taxes. And I think part of that has been educating clients and case managers and other outreach and enrollment folks about tax help that already exists, and really making sure that people know about those resources. Finally, and I think this is important, and something that is going to be part of that really front-end sort of frenzied month of plan assessment, is that plan coverage and cost may change for the 2015 benefit year. We've already heard reports of new plans entering the marketplaces or plans discontinuing coverage, not offering products for the 2015 benefit year. So, and I think it's important because there's been a lot of talk about auto-enrollment in plans, which for federally facilitated marketplaces and some state marketplaces, auto-enrollment is a great backstop for folks, so that even if you do nothing, you'll be automatically re-enrolled into the plan or a similar plan that you were in. And that's a good backstop, but I think it's important that to note that it doesn't negate the need for plan assessment, to make sure that your plan didn't change, and to make sure that the marketplace has a client's updated income in case a tax credit amount has changed. So that plan assessment is still going to be really, really important, even for folks who are currently enrolled in a plan. Next slide. So I think shown this map before, but just to note that insurance purchasing programs and insurance assistance through ADAP and Ryan White Part B programs has been essential to really help people access qualified health plans, to help people be able to afford the leftover amounts in premiums and in out-of-pocket costs, or copays, your deductibles. And as you can see from this map, the vast majority of states have statewide ADAP Part B insurance purchasing programs, and have for some time. This isn't a new thing for ADAP, although the ACA certainly does create an expansion of these programs. And so what I want to note is that for those states in red, I think it's important to note that states are working on and planning for insurance purchasing in many of those states. So, for folks on this webinar, I think it's important to check with your state ADAP about plans for insurance purchase, because some of the states that did not have a statewide insurance purchasing program for the 2014 benefit year will have one up and running for 2015. So next slide. And just very, very briefly, why have these insurance purchasing programs been important? Well, even with the premium tax credits and even with the federal cost sharing reductions, we have still seen sometimes pretty hefty out-of-pocket and premium amounts left over for clients for their contribution. And ADAP and Part B insurance purchasing programs have really been able to step in where the federal subsidies stop and really help people maintain access to affordable insurance. And Melinda mentioned some of the access issues, and one of them a trend that we saw in 2014 was really high co-insurance associated with HIV medications. So, ADAP have been able to help clients be able to afford that really high out-of-pocket cost where those programs have been available. Next slide. And now Stuart mentioned the Medicaid coverage gap, and I think it's really important to note that the Ryan White program and ADAP has really been working to help address what in many states is a very significant gap of lowest income, most vulnerable populations who do not meet current eligibility criteria for traditional Medicaid in states that didn't expand Medicaid, and then whose incomes are under 100% of the federal poverty level, so they're not eligible for federal subsidies to help purchase private insurance in the marketplaces. So Ryan White programs and ADAPs are doing a couple of things. In several states, Ryan White programs have been purchasing unsubsidized coverage for those people in the Medicaid gap, which has been huge and has helped thousands of ADAP clients get access to insurance. And then, in all states, the Ryan White program and ADAP continues to provide a safety net for those who remain uninsured. Next slide. So I wanted to end with a topic that has come up quite a bit, and I know that there are going to be some webinars and attention from HRSA on this in the coming weeks and months, but the HRSA HAB policy, I'm not going to go through all of these, really just the first one on vigorously pursuing client eligibility for public and private insurance. We saw our HRSA HAB, and we've seen, when they speak about this policy, really trying to thread a needle of number one, making sure that anyone who's eligible for new coverage is going to that new coverage, because the Ryan White program is the payer of last resort, but then also ensuring that the Ryan White program continues to act as a safety net. So next slide. So, there's been a lot of questions of what exactly does vigorously pursue mean, because I think it's somewhat deliberately vague. So, what HRSA has said, and what grantees are sort of acting on, is that vigorously pursue at its core really needs to be demonstrated policies and procedures that demonstrate that programs and grantees are screening folks for coverage and are documenting what they do in terms of outreach and screening and maximizing available coverage for folks. So, we've seen from an ADAP perspective this take a couple of different forms. Implementing new and more rigorous client eligibility screening policies that screen for Medicaid and or a qualified health plan and federal subsidy eligibility, documenting client contact, and requiring attestation if a client at the end of all of this screening and client contact, this does not enroll in coverage. And then the other piece of that, requiring clients to accept that full amount of premium tax credits in advance, and to acknowledge the need to report changes in income to the marketplace to really minimize any refunds that a client would be owed at reconciliation time if it turns out that they weren't paid enough in advanced premium tax credits by the IRS throughout the year. So those are just some examples, and I think, you know, as we go, we'll continue to see and document examples of what this looks like in practice, because I think it's going to look different depending on your state, depending on if your state expanded Medicaid. And what I think is helpful for grantees, and what has been helpful, is to sort of share, you know, what do these policies look like, and what are some of the procedures and processes that have worked on the ground. So I will end there and turn it over to our next speaker.
Great, thank you so much, Amy. That was really helpful. And we've gotten lots of questions, so please keep them coming. We are going to have some time here at the end, so just, you know, those questions that have been stumping you about the Affordable Care Act, this is your chance to ask them. So start sending them to me if you haven't already, and we will be asking them shortly or answering them shortly. So I'm going to turn things over to Lauren Banks, who's going to talk about AIDS Alabama and their work to enroll folks in the Affordable Care Act. Go ahead, Lauren.
Thanks, John, and thanks everybody for inviting us to participate in the webinar. AIDS Alabama is an AIDS service organization based in Birmingham, Alabama, and we were awarded a Navigator grant. So next slide. The Navigator grant was able helped us create Enroll Alabama, and so our advocacy department created this program to enroll Alabamians in the health insurance marketplace, which is federal facilitated marketplace in Alabama, Medicaid, as well as CHIP. Our model was that we were going to partner with 6 other AIDS service organizations around Alabama and 1 housing organization. So with this, we were able to be in all of the main city centers of Alabama and in the rural areas. We are also a state lead for Enroll America, so that when they have information, they pass it along to us and us to them. We employed a full-time project coordinator, 5 full-time navigators, and 4 part-time navigators. So we had a team of 10 people who were solely focusing on enrollment. We also had huge community support, over 100 volunteers. We actually had 60 volunteers take the navigator training and become certified navigators. And we had these 60 volunteers all over the state and had weekly phone calls with them, treating them as our paid navigators, telling them what was going on, what guidance we were hearing, best practices. And that has been a really good piece of our project, because it really has been a grassroots initiative to enroll people in the Affordable Care Act. We partnered with clinics, churches, clubs, organizations. We've been overwhelmed at the response of how many places wanted to partner. Even people that you wouldn't have thought would be for the Affordable Care Act have really supported us. Libraries have been a great community partner. So for those of you who are starting a CAC program or a Navigator program out there, libraries are a wonderful asset, and they oftentimes have computer labs where you can put people at computers and they can enroll, and you can walk around and help multiple people at a time. Our local NBC channel has been amazing. They have brought us in several times to do a call-in where they publicize on TV, hey, if you have questions about the Affordable Care Act or Medicaid or anything having to do with new insurance, call us. And so we have our navigators on screen like a telethon, and people call in with questions, and they are nonstop. That has been really tremendous. So if you can partner with a local TV station, it's a fun way to get the word out. Next slide. So our outcomes in Alabama, a total, not just us, but roughly 100,000 Alabamians enrolled during open enrollment. Since open enrollment, 3,000 to 5,000 Alabamians enrolled during the special enrollment period. That's about half of those who qualified for subsidies in the marketplace. So we were rather thrilled with those numbers. Enroll Alabama assisted 7,500 people in a one-on-one capacity of helping them enroll in a marketplace or CHIP or Medicaid. And then we've reached thousands through presentations, the community events. I just talked about like at churches and clinics and health fairs. That has been a tremendous outreach. Next. So we've learned our lesson on a lot of things, and we learned to only hire full-time navigators. Being a navigator is a lot of work, and people want answers immediately. So if somebody calls and learns that the person who's supposed to help them won't be in until Friday, they get frustrated, anxious, and our navigators come back and have 100 phone calls to return. Truly, over the weekend, we rack up over hundreds of phone calls to return. So this time we have another navigator grant. We're starting our second year, and we are only hiring full-time navigators. We also created a central toll-free number. This is because a lot of people don't know, if they live in rural Alabama, do they call this navigator or that navigator? And now we have a central intake system with somebody who is at the phone from 8 a.m. to 5 p.m. who can answer questions. Also, breaking down the components. Saying Obamacare or Affordable Care Act isn't always effective. It is to those of us who are in this work all the time, but for a lot of people, they really still don't know what the Affordable Care Act is or what options are available to them. So if we start at basics, we can help you get affordable health insurance. That opens the door a lot of time and helps us to level with people. Also, set aside at least 1 hour for every enrollment. In addition to enrolling people, people want to tell their story. They want to tell you how they wound up where you are. And whether or not you like that, that's just the case. Our navigators hear lots and lots of stories. But so as people are creating passwords and email accounts so that they can access this, they start telling you all their, all their stuff. And it takes a long time to enroll someone. So be cognizant of that when you're going in. Also, have snacks, children's toys, books, comfortable seating. It does take a while. People bring their kids oftentimes or their significant other or family members. So we've tried to make all of our atmospheres more comfortable for clients when they come in and something for kids to do. And then just be knowledgeable about what you're doing and not just the marketplace, but also Medicare, Medicaid, and CHIP. A lot of people just have general questions. And that's been helpful for us to have a basic command of those programs. And then be able to explain Medicaid expansion, especially if you're in a state that didn't expand Medicaid like Alabama. We have to tell people that they fall into the coverage gap. And that is very hard. And a lot of people get very upset and start to cry. Some get angry. But so having a way to convey Medicaid expansion is important. Next slide. So end on a positive note, and I guess all of this is positive because people get health insurance, but Andrew is a guy who now works at AIDS Alabama, but because of the Affordable Care Act and the health insurance marketplace, oh, his name split up there, sorry. Andrew was able to get health insurance for the first time, and I thought it was just since his HIV diagnosis, but ever in his life. This was the first time he was able to get private health insurance, and he is thrilled. He says it gives him dignity. He's able to pay something every month for his health insurance, and he is thrilled to tell his story. And Andrew is one of many people who are benefited by this, and we just need to continue collecting these stories, sharing these stories so that we can give the Affordable Care Act a good name. Thanks so much for your time.
Great. Thank you so much, Lauren. That was fantastic, and you were just doing phenomenal work in a place that really, really, really needs it. So thank you. So I have unmuted all of our presenters, and I'm going to start firing off questions to you all. So To our panelists, please keep your answers brief so we can cover lots of questions. And remember, please, folks out there in webinar land, you can chat your questions at us, and here's how you can ask them. And we will, if we don't answer your question today, do our best to follow up with them, with you as at a later date. So for the first question, and so some of these questions, just so folks know, are pretty detailed. So be prepared for that. But these are the kind of questions folks have that we want to answer. So the first question here is, do clients have to pay their premium for a qualified health plan by December 15th to have coverage on January 1 of 2015? Maybe Amy Kay, do you want to take that?
Sure thing. So not necessarily. The December 15th date is the date by which you have to enroll in coverage. So you choose a plan, you enroll in coverage, and then your plan invoices you. And every plan will be different in terms of when they need to receive that first premium check. And so, I've heard that it's varied from 10 days is the quickest turnaround that I've heard, all the way to 30 days. So that's a really important thing to check when your clients or you as an individual get your invoice from the plan, is when that first premium payment is due, and that's going to vary. But the December 15th date is the day by which you have to enroll in coverage.
And Amy, could you talk a little bit about, for people who are having ADAP cover their share of the premium cost, what are some of those deadlines to, because that you'd have to forward that premium notice to your AIDS Drug Assistance Program for them to cut a check to the plan. So what are some of those deadlines, and how does that process work in some states?
Sure. So, what we saw in the first year, and I think what we'll continue to see, is that, the first transition was primarily, clients who are already enrolled in ADAP. So ADAP was usually paying, for full pay medication, sometimes paying for PSIP, and it was a transition of ADAP clients to qualified health plans. But, the point there is that you have to be an ADAP client, right? You have to both qualify for ADAP, and that's a separate eligibility process than enrolling in a health plan and then getting your premium tax credits and your cost sharing reductions. So in a lot of states, the eligibility and the screening has really been done in tandem, right? So that you're being screened, you're going through the marketplace application process and enrollment process. You're bringing those documents to ADAP. ADAP has screened you for eligibility for ADAP, and then ADAP has the information from your health plan. So it varies by state, and I would make sure that you know what your own state's policy is. But at the very least, it's when you have to be both an ADAP client, and then once you enroll in a plan, you have to provide that plan information to ADAP so that ADAP has the appropriate address to send the check, amount, and all of that.
Great, thank you, Amy. Just want to remind everybody, if you have questions about how your state AIDS Drug Assistance Program is working, call them. Pick up the phone and call them and say, what do we do? How do we handle this? We're getting questions from clients. We want to know. And ask them what information they can share with you and what information you have to share with your clients. ADAP shouldn't be a mystery, and the ADAP staff are incredibly, incredibly helpful, and they want to get as many people signed up as possible. So, moving on, we have a question about employer-based insurance. So, in what situations could someone who is offered employer-based insurance turn that insurance down and get coverage on the marketplace? Can someone have coverage both from their employer and from the marketplace, or is there a requirement to have one or the other? Who wants to take that?
This is Stuart.
So I think there are two things to keep in mind. One is you can have employer-sponsored insurance and decide to purchase a plan on the marketplace, and you can make that decision for yourself. However, the key is, if you want to qualify for subsidies to help you pay for that insurance, your employer-sponsored insurance has to be less than, or the premium that you're paying, excuse me, has to be more than 9.5% of your income, and as well, your employer-sponsored plan has to pay for a certain percentage of services overall, so that's called your AV value. And so if your plan doesn't meet either of those standards, as far as affordability or coverage amount, then you are able to qualify for subsidies on the marketplace. But regardless, you could choose to purchase a plan. It's just that you wouldn't be eligible for subsidies. And others can feel free to add on if you have something to say.
Stuart, do you have any resources that explain employer-based insurance?
Well, actually, we were just talking that the eligibility tree does point out that is what Melinda just said, essentially, that it has to be over the 9.5% of your income to qualify for subsidies.
And that eligibility tree, which is available at the ACE TA Center, it's a great resource and very detailed, so definitely check it out. So another question that's come in is, sorry, I'm looking through my questions here. So for folks in states that are not expanding Medicaid, what are the best options for them? And so somebody from Florida asked, what are the AIDS Drug Assistance Program there can wrap around marketplace coverage. So could one of you talk a little bit about what folks in states where Medicaid has not expanded can do?
This is Amy. I mean, I can start
Yep.
and sort of give an overview of some of the things that we've seen. So, you know, in states where there is a statewide, like ADAP Part B insurance purchasing program, that has been a real benefit to help people who otherwise would not be eligible for coverage, who fall into that Medicaid gap, to get access to qualified health plans. So, and this is another, you know, it's going to vary by state. Some states have been able to purchase for folks under 100% federal poverty level, so they're purchasing unsubsidized qualified health plans, because remember, those people under 100% federal poverty level, they are not eligible for the premium tax credits and cost sharing reductions. So in some states, you know, even those very, very low income folks under the federal poverty level are able to access qualified health plans because ADAP is purchasing coverage. In other states, the eligibility for who ADAP is helping is different and maybe above 100%. So that's going to vary by state. And in the states, so I showed the map where there are several states that, at least in the 2014 benefit year, there wasn't a statewide ADAP or Part B insurance purchasing programs. Even in those states, other Ryan White grantees were able, on a smaller scale, to purchase insurance for folks to help people with their premiums and out-of-pocket costs to get marketplace coverage. I know, you know, Alabama and Texas were examples of states where that happened. So, you know, that's another sort of local resource to investigate to see if there are other grantees who are able to help folks with insurance purchase. And then I think it's important just to note that in every state, the Ryan White program and ADAP has not gone away and remains a safety net for people who don't have access to insurance. So as it always has been since its inception, Ryan White and ADAP is providing essential care and treatment for folks who are eligible and have nowhere else to go. So I think that's been an important safety net that has continued and is even more important in states that have not yet expanded Medicaid.
Great, thank you, Amy. Another question that we've gotten is, what happens when someone enrolls in a marketplace plan and maybe they lose their job and their income changes, or if they change employers? What should people do in that situation if their income changes during the year?
Well, this is Stuart. I think that's sort of a classic situation of what triggers a special enrollment period. And so you would have an option to then sort of enroll in a different plan if that was necessary. I don't think you can, and someone else maybe on the panel knows this, could change the subsidy for the existing plan at that moment in time. I think that would be reconciled at the end of the year. But again, it would prompt a special enrollment period where you could purchase a more affordable plan or potentially apply for Medicaid if that was what would happen, if the person was then eligible after losing a job, for example.
It's a really great point, Stuart, about special enrollment periods. So there are all kinds of reasons why that people can enroll during the year outside of the regular open enrollment period. So an example that Stuart just gave is if someone loses a job and loses employer-based insurance. Another example is if you get married or divorced or have a kid. It seems like there are new special enrollment periods released every month. So whenever someone has a change in their life circumstances, whatever that might be, it's probably a good idea to check and see if there's a special enrollment period for that specific issue, because there are lots of reasons folks can enroll out there. Anyone want to add anything to that?
Yeah, this is Lauren.
I
would like to. Oh, go ahead.
Go ahead.
Go ahead, Lauren.
Lauren, you're up.
I was going to say, if you wanted to keep the plan that you were on, and say you lost your job, but you wanted to keep it, but you knew you were going to fall in for a subsidy, at the end of the year when you file taxes, you get to reconcile how much you paid versus how much assistance you're going to get back.
Yep.
So say you had been paying $200 a month for your plan, and in September you lost your job, and so your income for the year was going to be down a little bit. Well, at the end of the year, they're going to give you a tax credit that says, okay, well, you paid more for these last 3 months than you should have, so we're going to give you back, say, $100 a month or whatever it is. So you can choose to keep that, and then also if you get a raise, same thing. Then more money would be taken out at the end during reconciliation.
Jen, did you want to add something?
Yeah, I was going to underscore what John said, which was anytime you have experience any kind of change, it's really important to check with your case manager or somebody in the marketplace to see if you're eligible for some kind of reconsideration. And that could, in addition to the life-changing events that John mentioned, like getting married or having a kid, you can also face a really unexpected medical condition, and that could count. So I think just the main message is if you are experiencing a change that is disruptive or just changing something basic about what's going on in your life, it's really important to reach out and see if there's accommodations that need to be made.
Unfinished casework is another really important special enrollment period. So if someone has a problem getting their paperwork completed or has an administrative glitch in their paperwork, for example, sometimes ADAP paperwork can count to that, ADAP premiums, and also just insurance enrollment issues and plan selection problems can also trigger a special enrollment period. So anyway, we have spent a lot of time on that. Let's move on. We got a question from somebody who lives and works in a state that did not expand Medicaid. And so what can folks in those states do to expand Medicaid and participate in efforts to expand Medicaid? Lauren, maybe you want to talk about that a little bit?
Sure. You can email me. I would love to talk about this. We are starting a new program in Alabama to work on expanding Medicaid, and this is just some good grassroots advocacy. We write letters to the governor asking for Medicaid expansion, go to talk to legislators, state legislators, asking them to put pressure on the governor. We just had a huge get out the vote yesterday around the issue of Medicaid expansion, and not party-driven, but just these are the issues that matter to us, and we're going to vote. So that, also working with partners, other disease groups who would also benefit from Medicaid expansion, hospital associations. A lot of churches are super involved in this. There are a lot of people who want Medicaid expansion outside of the HIV/AIDS community. But truly, you can email me. I'm sure that all of our information is up on the slides, and I would love to talk about Medicaid expansion efforts.
Great, thank you, Lauren. You and the rest of the Alabama folks are really leading the charge on that, and are a great example of a cross-disease group coalition and cross-organization and across the health sector that's been working together to advocate for Medicaid expansion. So another question that's come in. We're cheering for you. Another question that has come in is, what resources are available for folks who are undocumented? And can ADAPs, for example, purchase insurance for them off the marketplace? And what ADAP and Ryan White services are available for folks who are undocumented?
Sure. So this is Amy. I can start on that one. So first, as I said, and I really do think that this point sort of deserves emphasis, that ADAP and Ryan White continues to be a safety net, and folks who are categorically ineligible for federal programs will continue to be eligible for Ryan White and ADAP services. In some states, ADAP has been able to purchase off-marketplace plans for folks who aren't eligible for to purchase insurance on the marketplace. And I would say that's another issue and question that is state-specific, and to check with your state about whether that's a possibility. The plans outside of the marketplace have varied in terms of how open they are and what their eligibility criteria are. Some do require a Social Security number, so that's obviously a barrier. Some just require a premium check, and so in those instances, there have been some creative solutions and ways to get access to insurance, but that is a road that some ADAPs have been able to go down.
This is Stuart. Can I just add that New York State and California have really, I think, been in the lead in trying to find alternative solutions for health insurance for undocumented individuals. So folks who are maybe looking at this from an advocacy perspective might want to look into the strategies being pursued in those states and see if there's any appetite for it where they're based.
That's a great point. Thank you, Stuart. This is an interesting issue, and one that we've been challenged with here. Many consumers who have been uninsured have been getting coverage through the Ryan White program for all their services, and really have had to pay nothing for those services. And when they transition to new insurance coverage, they suddenly have to pay out-of-pocket costs for lab services, for a doctor visit. What are some of the resources that are available to educate consumers about that, and how have some of you heard about programs working to educate and help consumers with those challenges? Stuart, do you want to talk about some of your resources to start?
Sure. First, I would talk about the discussion guide that we've put together, which just helps the folks doing the outreach and enrollment have discussions about the benefits and value of insurance, and the fact that some of the services, for example, that they may want to have, like a annual physical with a doctor does not have any, is 100% covered under a qualified health plan. So there are no co-insurance costs. And the same are similar for certain other preventive services like mammography, et cetera. In addition, there are services like ADAP that could potentially help support some of the costs. There's also the cost-sharing reductions that could be available to people with marketplace plans that could help abate some of the co-payments, et cetera. So there are a variety. So some services may not have any co-pays or deductibles to worry about, or there may be resources through Ryan White or cost-sharing reductions to help provide services for support for some of those costs.
And this is Melinda. I just want to also add that there are some other programs that provide cost-sharing assistance. Drug companies have patient assistance programs for people who are uninsured, and sometimes have cost-sharing assistance programs for people who can't afford just the cost-sharing. There's also the Patient Access Network Foundation. So there are some additional resources in addition to ADAP and Ryan White that can sometimes help with the cost of medications.
And this is Amy. Just to add just one small caveat. So we have seen the office visits and the lab visits, lab copays, the medical copays be a barrier. And one of those reasons is that ADAP funds can't be used for medical copays. So in some states, they've been able to use Part B or state funds to fund those services. But we've also seen some creative strategies of the Ryan White or ADAP working to cover the premiums and prescription copays, which ADAP funds can be used for, and then working hand in hand with other Ryan White grantees like Part C providers and medical providers for payment of some of those medical co-payments, and really trying to use the entire Ryan White program village. But it's been a challenge, and it's one of those things that does. It bears checking with your state to see what's available, because it does vary state by state.
That's a really great point, Amy. That this is that paying medical copays is a great example of where programs really do need to work together and to coordinate. And it's not easy to make that happen, but of course it's really critical. So a couple of folks have asked how they get navigator training and how they become certified application counselors. Can any of you address that?
This is Lauren. I'll take a stab and y'all can jump in. Navigators were awarded through a grant. So there are navigator entities in every state that has a federally facilitated marketplace, and then some or most that are state-based marketplace. So you can do a search to see who it is in your area that is a navigator, and you can contact them, and they can sign you up with their navigator account and get you, sign up for the training. You can do it on your computer or laptop, anywhere to access the internet. And it's a 25-hour training, and you can go at your own pace. And once you are finished, you get a certificate, and you can go out and help enroll people in a plan. With certified application counselors, you can also find a community organization. Some got grants to do this, mainly FQHCs. So if you have a federally qualified health center in your area or a hospital, they might have a CAC grant. Also, many community organizations have signed up to be certified application counselors, and they can also let you know. You can go on healthcare.gov and do a look for who is helping people in your area, or at getcovered.org, and they will also, and Stewart's website also may do that to show you who it is in your area who's helping people. So contact them, they can get you hooked up with the training, and then you can go and volunteer.
Thank you. That's a really good point that individuals can contact local funded navigators. But it's important to know that any organization can become a certified application counselor organization. And sponsor their employees to become certified application counselors. There's no cost associated with that. And in fact, we strongly, strongly urge any and every Ryan White funded agency to become a certified application counselor agency and to have certified application counselors on staff. Every agency has to meet the Ryan White payer of last resort requirement, and HRSA and Part A and Part B programs are going to be working to enforce that requirement. And so one way that you can demonstrate movement towards complying with the payer of last resort requirement and the requirement that you quote-unquote vigorously pursue enrollment is by having certified application counselors in your organization. So another question about signing people up. In what cases and where and how can you help people sign up for insurance? So can you help them over the phone, or does a client have to be physically present to help someone apply? Lauren, do you know the answer to that?
Sorry, I was on mute. Yeah, you can absolutely help them over the phone. Healthcare.gov has people that help people over the phone. So if you're a navigator or case manager, yeah, I mean, you absolutely can. It's much easier to do it in person, but yeah, you certainly can. We meet people at their homes or at libraries or public places or have them come into the office. So it just is what's best for the client if they're homebound or, you know, they don't have the internet. Another resource, we have hot spots that we take with us to places in Alabama. A lot of it's rural, and people don't have the internet in their homes a lot of times. So yes, you can do it wherever, whenever.
That may be different for certified application counselors and for state-funded in-person counselors.
Okay.
Or navigators, because we have an in-person counselor program, which is pretty much the same as Navigator, but we are not allowed to enroll over the phone. So it's important to check. But it is possible to do, for example, a three-way call with the marketplace, and every marketplace, state or federal, has a call-in number, 800 number, obviously. So you can do a three-way call with a consumer and the marketplace if for some reason they're not able to come in. So any other comments or clarification on that one? That was a little bit of that's a tricky one. Okay, we have time for maybe one or two more questions. So I'm sorry, looking at my questions here. So here's a good one. Are consumers are consumers required to take premium tax credits up front, or can they take them later?
So this is Amy. I can start on that one. So the premium tax credits for everybody, they're available for, you can either get them in advance, meaning that as soon as you enroll in coverage, the tax credit is applied to your premiums monthly by the federal government right when you enroll. You don't have to wait till tax time. But you have the option of, even though you're eligible for premium tax credits, you're still going to pay full freight throughout the year, and then you'll get your tax credit as a refund when you file your taxes. I will say where this changes is that if you are getting assistance from ADAP, where ADAP is paying what's left over of your premiums, ADAPs are requiring for them, and I think this is across the board. You know, some might have language of encouraging, but my understanding is that it's requiring for the vast majority clients to take the full amount of the premium tax credit in advance. So you can't opt to get to your premium tax credit amount as a refund. And the reason for that is that the refund will go to the client, right? But in that case, ADAP would have been paying the client's portion of the premium all year. So the refund is really owed to ADAP, and ADAP does not want to be chasing refunds from clients to then try to get that back. Plus, there's not a whole lot of clarity about whether that refund amount will be able to be parsed out from the rest of an individual's tax refund that they may have gotten for other stuff. So that's an important thing to look at when you're looking at ADAP eligibility for insurance purchase, that ADAPs are really going to require folks to take the full amount of that premium tax credit in advance.
Great, thank you, Amy. We are going to wrap things up. If we have just one reminder here, please speak up about problems that you are having as we go into open enrollment and as you see issues with coverage this year. We really need your on-the-ground, real-life examples to provide information to regulators and policymakers about the problems that folks are having out there so we can address them. Remember that open enrollment starts November 15th, 10 days from now, and folks need to enroll by the 15th of December for coverage starting January 1. We strongly encourage anyone who has coverage now to very carefully evaluate plans that are out there and make sure they're enrolling in the right plan for them. The marketplace will be re-enrolling people this year in the same plan they had last year or a similar plan. And it's very possible that the plan has changed and won't be good for that individual anymore. So it's very important to check coverage again. I want to thank all of our presenters today, and we will be sending out an email shortly with links to the slides, the recording, and follow-up information. So thank you all very much, and please reach out to us if you have follow-up questions. Thanks. Bye-bye. Have a great day.